So good evening, everybody. I welcome you for today's session on this is the last part of sepsis symposium what we started. So we will end with HIV in pregnancy. So we'll discuss the obstetric part as well as the pediatric part. This is essential because just last year, NACO came up with newer guidelines about management of HIV in pregnancy as well as prevention of parent-to-child transmission. Let's learn from our speakers today what's new. I think to moderate our session, we have Dr. Vandana Madam today. So we welcome you, Vandana Ma'am, for the session.
Thank you, sir. Good evening, sir.
Good evening, ma'am. Good evening. I think Dr. Chandrika has mentioned she will join in between. So, obstetric part today, Dr. Chandrashri, who's consultant obstetrics and gynecology at Sarji Hospital, Shimoga, to start with the obstetric part.
Good evening, everybody. I, Dr. Chandrashri, working as a consultant obstetrics and gynecology at Sarji Hospital, Shimoga, will be talking on the management of HIV in pregnancy. Here we will be discussing under the case scenarios. Today, my first case scenario is Mrs. A, 24-year-old female, married to a truck driver in 2017, was initiated on antiretroviral therapy in 2018 on tenofovir, lamivudine, and efavirenz. She is adherent to the ART therapy. She has now reported to the ART center and informs that she is 2 months pregnant. Her latest results of viral load testing was normal, that is target not detected. How do we manage such a case when she comes to the clinic? It will be discussed under following objectives. How to manage HIV in pregnant women, when and whom to start the therapy, what regime of ART to be started, how to monitor the side effects of ART on pregnancy, and how effectively to prevent the mother-to-child transmission. This is the graph showing that there is, from 2010 to 2020, there is a declining trend of HIV epidemic in India. That is, the adult prevalence has decreased. But coming to the mother-to-child transmission, in 2010, out of 100 mothers, 40.2% were the chances of mother-to-child rate of transmission was 40.2%. But now in 2020, it is 27.4. So our basic idea is to bring this mother-to-child rate of transmission to 0%. What is the estimated risk and timing of prevention of parental to child transmission in the absence of interventions, that is without any treatment or interventions? Risk of HIV transmission, that is during pregnancy, the transmission rate will be 5 to 10%. During labor and delivery, it will be 10 to 15%. During breastfeeding, it will be 5 to 20%. Overall, without breastfeeding, it will be 15 to 25%. Overall, with breastfeeding to 6 months, it will be 20 to 35%. Overall, with breastfeeding to 18 to 24 months, it will be 30 to 45%. What with ARV interventions? As we have previously discussed in the slide, no ARV breastfeeding is 30 to 45%. No ARV, no breastfeeding is 20 to 25%. Short course with one ARV and breastfeeding is 15 to 25%. Short course with one ARV and no breastfeeding is 5 to 15%. Short course with two ARV, no breastfeeding is 5%. So 3 ARVs and no breastfeeding is 1%. That is, we have to give the retroviral therapy so that the mother to child transmission risk, that is transmission rate, will be reduced to 1%. So 2 ARVs breastfeeding unknown and 3 ARVs breastfeeding is unknown. What are the routes of vertical transmission? It is 20% in utero, that is before 36 weeks. And coming to peripartum, it is 80%, and we all know it is divided. Intrapartum, it is more, that is 50 to 60%, and in postpartum, it is 30%. Where in intrapartum, that is the onset of placental separation, mother-fetus microtransfusion, rupture of membranes, prolonged rupture of membranes and labor, breaks in skin of the baby, and through breastfeeding in postpartum period related to the duration. How do we reduce the perinatal transmission? The risk can be less than 1%. The transmission risk can be reduced with effective antiretroviral therapy and elective cesarean section and formula feeding. This is according to the Western guidelines, that is RCOG Green Top guidelines. Coming to our NACO guidelines, Indian scenarios, the mother to child transmission, if we implement the guidelines and start the ART as early as possible, then we can reduce the risk of less than 5% in breastfeeding infants from 35% and less than 2% in non-breastfeeding from 25%. There is increased chance of survival for both mother and the baby. How do we do the HIV screening? It is basically an opt-out testing. Whenever a mother walks into our antenatal clinic, we usually counsel the patient and we add this HIV testing along with the other screening tests and tell the patient the importance. If she refuses, then we will recounsel the mother in the next visit. Suppose if repeat testing is done in third trimester, it is recommended in areas where the incidence is more. For acquiring the HIV during pregnancy, we do a repeat testing in the third trimester. HIV testing, it is provider initiated opt-out testing. Informed as part of battery of routine ANC tests, patient has to specifically refuse. And if she refuses, then it is recounseled her the importance of the HIV testing, and it is just done in the next visit. And if negative, you are most likely not infected with HIV through the test may not detect the recent infection. So the retesting has to be done at 32 weeks if negative in generalized epidemics. If positive, then we have to initiate the treatment for HIV to reduce the mother to child transmission and counsel the partner testing. So basically it is a one test, two life saving. That is, prenatal HIV screening benefits both mother and the baby. How do we do HIV screening? Initial screening, ELISA, we do, that is the sensitivity is more than 99.5%. If it comes indeterminate, then the confirmatory test is done by Western blot method, immune fluorescent assay, which is the highly specific. Women with limited prenatal care or with undocumented HIV status at the delivery should have a rapid HIV test performed. How do we diagnose in clinically asymptomatic individuals? We have basically three assay, that is A1, if it is positive, then if it is negative, then the report is considered as negative. All three assay has to be positive if the patient has to be, if the report has to be positive with past test counseling. And it is taken as indeterminate if two of the test assays are positive and one of them is negative. And if it is one positive and two negative, then we have to consider it as a high risk or indeterminate. And if it is low risk, consider it as negative. Diagnosis in clinically symptomatic individuals. If both the assays are positive, then the report positive with post-test counseling. Then it is indeterminate if two positive and one negative is there. And if two negative and one of the assays is positive, then it is report negative. What is the effect of pregnancy on HIV? There is no deleterious effect on progression of the disease. The decrease in the absolute CD4 counts, changes in the levels related to the hemodilation of pregnancy and normalizes after the delivery. There is no significant change in the RNA levels or CD4 counts. Effect of HIV on pregnancy. If in untreated women, symptomatic and advanced diseases, that is stage 2 and more, is associated with significant increase in the risk of preterm delivery and low birth weight infants. No increase in malformations or related to the HIV infections has been observed. Is amniocentesis safe in pregnant women with HIV? Yes. If women on effective ART, there is no Perinatal transmission have been reported after amniocentesis, but a small risk of transmission cannot be ruled out. So amniocentesis should be performed on HIV infected women only after initiation of the effective ARP therapy regime. Ideally, when HIV RNA are undetected. This is the WHO staging system for HIV. It is same for both pregnant and non-pregnant status. That is stage 1, 2, 3, 4 and wasting syndrome. When to start the ART? Initially in 2010 to 13, we used to wait till the CD4 counts was decreased and then we used to start the ART therapy. But now, according to the recent NACO guidelines, when should we start the ART is all the persons who is diagnosed with HIV infection should be initiated on ART regardless of the CD4 count or WHO clinical stage or age group or population subgroups. When to do viral load testing? For all the patients on first line of ART therapy, plasma viral load testing should be done at 6 months and 12 months after initiation of ART therapy, and thereafter it has to be continued annually. For all patients on second or third line ART, plasma viral load testing has to be done every 6 months after initiation of second or third line ART. And the medical officer can request as and when required the viral testing if necessary during the one drug substitution or new clinical event. Plasma viral load testing is always recommended for all HIV positive pregnant women during the 32 to 36 weeks of pregnancy, regardless or duration of the ART, to determine the risk of HIV transmission to the baby. See here, this is the decision tree for ART in pregnant women. That is both for pregnant and breastfeeding women in HIV. Here, we divide accordingly. The HIV detected during the routine antenatal care. She's first time she's come to the antenatal clinic. We are going to do the test and she's come as positive. How do we manage? Next scenario is pregnant woman who's already registered in the ART center. Next is pregnant woman who's already on ART, currently transitioned to the TLD regime. Next is women who came directly in labor, and next is HIV detected in the postpartum or breastfeeding woman. So what do we do? HIV detected, she's freshly diagnosed as positive case in her pregnancy. We have to link her to the ART center immediately. At ART center, we have to initiate the ART as per the NACO guidelines, regardless of CD4 count. Perform the viral load test between 32 and 36 weeks of pregnancy to assess the risk, that is high or low risk HIV transmission. And so we have to ensure everyone the institutional delivery and follow. For infants, ARV prophylaxis, dual drug prophylaxis in high risk HIV transmission and single drug prophylaxis in low risk HIV transmission. When the pregnant woman is already registered in ART center, at ART center, initiate ART as per the NACO guidelines, regardless of the CD4 count, perform the viral load at 32 to 36 weeks of gestation, and high and low risk we have to do, and then we have to deliver her in the institution and follow up and ensure the infant the ARV prophylaxis. Pregnant woman already on ART and she is being transitioned to TLD, that is tenofovir, lamivudine and dolutegravir regime, which is the recent regime according to 2020-21 NACO guidelines. Perform viral load again at 32 to 36 weeks of pregnancy to assess the high and low risk, deliver her in the institution and follow up and ensure infant ARV prophylaxis. Woman who came directly in labor, she has come in labor and you are going to do a CAR test and she is positive. What are you going to do? You have to perform HIV test and take the blood for CD4 count. Initiate ART, give first dose as per NACO guidelines, follow up with confirmation of the status at ICTC. Ensure the linkage ART center immediately in postpartum period and continue same regime and ensure infant ARV prophylaxis. HIV detected postpartum in breastfeeding women. What are we going to do? Same thing, ensure linkage ART center immediately and initiate ART as per NACO guidelines and ensure the infant ARV prophylaxis. What ART to be given in pregnant women? Pregnant and breastfeeding women with HIV, the preferred ART regime as a tenofovir, lamivudine and dolutegravir. It is the single drug regime to be given once daily. It is given including HIV 1 infection, 2 infection, and with co-infection, and with women exposed to single dose nevirapine in the past or co-infected with hepatitis B and tuberculosis. Pregnant women with HIV should be educated about the benefits and risks of the dolutegravir to help the informed choice. If she is presenting in active labor, no prior ART, then we have to initiate the TLD regime and continue the TLD regime in the postpartum period. What are the factors influencing the perinatal transmission? There are three factors, that is maternal factors, obstetric factors, and infant factors. Maternal factors are the RNA levels, the CD4 counts, the co-infections like hepatitis B, CMV, maternal injection drug use, lack of ARV during pregnancy, seroconversion during feeding, obstetrical factors like the duration of the ruptured membranes, associated chorioamnitis, vaginal delivery, invasive procedures, and if it is twins. Infant factors like oral thrush, breastfeeding, and prematurity. What are the precautions we have to take in labor, conducting the delivery or labor and delivery of the positive patients? We have to avoid basically the prolonged labor by using the pantograph, as we all do in our labor rooms. We have to avoid ARM and prolonged rupture of membranes. Minimal vaginal examination has to be done. Avoid routine episiotomy. Invasive procedures such as fetal scalp electrode placements, insertion of intrauterine pressure catheters, fetal pulse oximeters has to be avoided. Avoid the instrumental deliveries, and methergine has to be avoided as it interferes with the protease inhibitors and effervescence. What are the precautions you have to take during cesarean? We have to start ART. Early cord clamping has to be done. Avoid rupturing membranes until the head is delivered through the surgical incision. Use of round blend tip needles, peripartum antibiotics, universal precautions followed. What are the indications for cesarean? According to NACO, in Indian scenario, cesarean is done only for the obstetric indications. Whereas in Western countries, the RCOG guidelines, the vaginal delivery only on highly active antiretroviral therapy with viral load less than 50 copies per ml. Rest all LSCS at 38 weeks to prevent the leaking. ACOG, same elective LSCS at 38 weeks if viral load more than 1000 copies per ml or unknown load. Coming to the premature rupture of membranes with HIV positive status women. If it is more than 34 weeks, then you have to deliver the patient by augmenting the labor. Less than 34 weeks, antenatal corticosteroids has to be given in the absence of intraamniotic infections. Then deliver. Less than 28 weeks, as the risk of prematurity will be more, the management has to be individualized. If controlled in ART, then expected management till reasonable fetal maturity is attained. Antibiotic prophylaxis has to be started with erythromycin and ampicillin. 2% increased risk with every hour of leaking. If it is more than 4 hours leaking, it doubles the risk of transmission. The era of HART. Transmission rate is 1%. If leaking is less than 4 hours, that is 1.9% if it is more than 4 hours. What is the postpartum care? We have to ensure the continuation of the ART therapy. Risk of resistance is more if she misses more than 3 doses in a month. No mixed feeding, as it increases the risk of infection. We have to treat the cracked nipple mastitis, and postpartum blues are increased, so we have to counsel the patient accordingly. Affects ARV adherence. Antibiotics prophylaxis is continued. Contraceptive advice is given. Additional case scenario. As we have already mentioned the first case scenario, coming back, Mrs. A was initiated on ART in 2018 and TLE, that is tenofovir, lamivudine, and efavirenz. She is adherent to ART. She has now reported to ART and informs that she is 2 months pregnant. How do we proceed here is the counsel her with respect to the transitioning to TLD regime. We have to counsel her and we have to change the regime, and ART adherence has to be done. Linkage to the prevention of mother to child transmission program. Protected sex practices has to be given, and institutional deliveries has to be supported. Interventions during labor and delivery and timely early prophylaxis to the baby. Feeding practices and care of the breast and nipples, nutritional supplementation, regular antenatal visits, and supplementations has to be given. Coming to the second case scenario, she's Mrs. B was initiated on ART in 2020 on TLD. As we all told, it is tenofovir, lamivudine, and dolutegravir. and she reported that she was 2 months pregnant. She missed an ART visit in February 2021. She was linked back to the ART center in March 2021 by the officers. And how the ART-MO, what are the actions will you take? How is it managed? This may not have happened if mother has been counseled properly, and the role of adherent ART in preventing the HIV infection in her baby. If she was properly counseled, she wouldn't have missed. So we have to counsel the patient, the importance of preventing the mother to child transmission, and resume TLD regime. Counsel her with respect to the role of ART adherence to her health and preventing the transmission, and linking them to the PPTCT program. The third case scenario is Mrs. C received triple drug ARV prophylaxis as in 2012 during her first pregnancy. She was advised TLE once a day as prophylaxis, and it was stopped 7 days after discontinuation of breastfeeding. Now she reports to ART center with 2 months of pregnancy. Her latest CD4 count is 420 cells per millimeter cube. So what ART regime should she be advised? So Mrs. C needs to be started on ART immediately after explaining the need for lifelong ART adherence. Hence, recommend Mrs. C to initiate on TLD, 1 tablet once a day. For infant feeding, always consult the neonatologist, and our fellow pediatrician will be discussing regarding this, and also according to the NACO guidelines. Coming to the fourth scenario, Mrs. D has reported to ART center at 7 months of pregnancy. She's ART and her CD4 is 385 cells. What ART regime should be initiated on? Mother's viral load report done at 36 weeks of gestation was 20,000 copies per ml. She plans to breastfeed the baby. How do we manage? She needs to be started on ART immediately after explaining the need for lifelong ART adherence, and advise her TLD 1 tablet once a day, and infant feeding, she has to consult the neonatologist. Coming to the case scenario, fifth scenario, that is Mrs. E was advised a single dose nevirapine as prophylaxis in her previous pregnancy in 2011. She was later initiated on TLE in 2014. She has now reported on ART center at 3rd month of pregnancy. So what ART regime should be initiated? As we discussed before, transition ART regime from TLE to TLD after explaining the benefits of dolutegravir and achieving fast suppression. And we have to counsel the patient, and TLD is effective in women with history of single dose nevirapine 3 days. So the sixth case scenario is Mrs. F is an asymptomatic postnatal positive live HIV who presents at ART center 3 days after the delivery. This is after delivery. Her CD4 count was done and it was 550 cells. She has opted for ERF, and weight of the baby is 2.4 kg. What is the next step in the management of the mother? Mrs. F needs to be started on ART immediately, and explaining the need for lifelong ART adherence. TLD 1 tablet once a day, and linking her to PPTCT program. Coming to 7th case scenario, Mrs. G was screened for HIV and found to be reactive by the finger prick test in the labor room. That is, when she walks into the labor room, she was tested positive. She's in labor. She was immediately given a single dose tablet of TLD, and she was linked to the ART center. And next day, after her confirmatory test report of HIV positive, weight of the baby is 2.8 kg. So how do we manage? Mrs. G needs to be started on ART and explaining the need of lifelong ART adherence, and TLD treatment has to be taken, and we have to link her to the PPTCT program. So 8th case scenario, it is 24-year-old newly diagnosed HIV positive pregnant woman linked to ART center. She has confirmed HIV 1 and 2 co-infections. She is 3 months pregnant and her CD4 is 700. So basically what we are trying to tell is, irrespective of the CD4 or co-infections, we have to start the patient with the ART regime, that is TLD, immediately after explaining the need for lifelong ART adherence. And it is effective for both 1 and 2 co-infections. Coming to the 9th scenario, it is K was diagnosed HIV infected recently. She has reported to an ART center and informs that she is 6 months pregnant and her CD4 is 285. The same scenario is followed here. We have to immediately start her on ART and advise her if she needs to be started on CPT also, as her CD4 is less than 350, has to be started. This is CPT's cotrimoxazole regimen. Additional case scenario 10, that is Mrs. L, 26 year, was registered at ART center in 2012. She was initiated on ART, that is TLE, in 2015. She became last to follow up after 1 year as she shifted to her village. She is now reported in active labor. So how is this patient managed? The patient is started with a single tablet TLD immediately, and she has to be linked to the ART center. And next day, for restarting the lifelong ART treatment, advise mother regarding the role of ART adherence to her health and preventing the mother-to-child transmission. So thank you everybody for your patience listening. And I have not discussed the side effects of each drug in this discussion because it will take a lot of time. And I would like to share the NACO guidelines at the end, so you can please refer accordingly. Thank you, everybody.
So thank you, Dr. Chandrashri, for that wonderful presentation. It was very clear. So I think we have now handled the obstetric part. Let's now look into the challenges what a pediatrician would face when we are there to attend a delivery for a HIV positive mother. I would now like to invite Purna Chandra Rao, who is a fellow at Ovam Hospital, to present the pediatric concerns and challenges in managing a baby born to HIV positive mother. Purna Chandra, you can actually share your screen. You can have the question or doubts at the end of it. You can also type in your doubts in the chat box. We can handle all the questions at the end of it. Over to you, Purna.
Okay, sir. So, am I audible?
Yes, Purna, yes.
Yes. So, good evening, everyone. I'll be dealing with HIV in pregnancy, pediatric perspective. So, first scenario, let us take a 24-year-old female married to a truck driver in 2017 and was initiated on ART in 2018 on TLE. She is adherent to ART. She has now reported to ART center and informed that she is 2 months pregnant. Her latest test result of the viral load testing was target not detected. Let us move on to next slide. So what are our concerns? Our concerns could be from a pediatric perspective. So what would be the delivery room management? So what do you tell about breastfeeding? What prophylaxis you give to the newborn? And what about the vaccination? And how do you follow? And finally, healthcare worker precautions. So let's move on to. So there is a 4-pronged strategy advised by NACO. In this, they are mainly concentrating upon prevention of maternal to child transmission. So, and it's a about this, that is factors associated with increased parent to child transmission of HIV, maternal and obstetric factors. Am I audible? Hello?
Purna, you're audible. I think slide number 6.
Oh. Yeah. Maternal obstetric factors, recent HIV infection in mother, high viral load, advanced disease in mother, STIs in mother, procedures, maternal malnutrition, conditions of breast like sore nipple and all. So infant-related factors are like preterm or low birth weight, and condition of baby's mouth, that is if there is any ulcers, and mixed feeding. These are the risk factors associated with parent to child transmission of HIV. So PPTCT interventions during pregnancy, ma'am already discussed. We'll discuss about intervention during labor and delivery. So if you see the delivery part, like immediately after birth, so all routine care should be continued except with 2 things. That is, avoid routine suction after birth, and if necessary, use suction pressure less than 100 mm of mercury. So, and also avoid delayed cord clamping or cord milking. That means you have to clamp the cord early. These are the two changes. And if we move on to the last prong, that is support of the infant. So what are the concerns we find in infants? So this is also repetition slide, but therapy, chance of transmission is high, if we can see. And if only one course of ARV is given, it is reduced almost 50%. And if regular three ARVs are given, with breastfeeding also it is 2%. And with no breastfeeding, it is 1%. So this is very significant slide, considering that ARV prevents parent to child transmission. And if you are giving all three drugs, and it will prevent almost from like 30 to 45% to 1%, we can prevent. So what are our concerns with feeding? So there are two types of feeding which we can practice in baby with HIV, like mother, either exclusive breastfeeding and exclusive replacement feeding, that is infant formula or dairy, etc. But while you are giving exclusive replacement feeding, avoid bottle feeding, use spoon or alada. So what are the recommendations for it? So in Indian scenario, counseling for infant feeding should begin within the antenatal period itself. And as per NACO, exclusive breastfeeding is recommended for India. So exclusive breastfeeding is recommended as a preferred choice of infant feeding for HIV exposed infants in India, to be minded. And mixed feeding increases the risk of HIV transmission and should be avoided. This is the recommendation with respect to exclusive breastfeeding. What if the parents want to go for exclusive replacement feeding, even if the transmission chances are like 1% compared to 2%, even they want to reduce that 1% also. So this should be considered feasible, acceptable, sustainable, and safe. Only if these criteria is met from the parent side, then only we should give exclusive replacement feeding. So we now go upon prophylaxis. So what prophylaxis and when? So you'll see HIV risk status, low risk infants and high risk infants. What are low risk infants? Infants born to mothers with suppressed viral load, that is less than 1000 copy, done anytime after 32 weeks of pregnancy up to delivery. So in this kind of situation, use nevirapine syrup, single ARV prophylaxis. Whereas in high risk infants born to HIV positive mother, not on ART, maternal viral load not done after 32 weeks of pregnancy till delivery, maternal viral load not suppressed between 32 weeks of pregnancy till delivery, mother newly identified HIV positive within 6 weeks of delivery. So in this kind of situations, use syrup nevirapine, syrup zidovudine along with it. This is dual therapy, dual prophylaxis. So must be clear, low risk infants, single syrup nevirapine, high risk infants, dual therapy. So what prophylaxis? Nevirapine, how much? So if birth weight between 2 kg to 2.5 kg, it is 10 mg, that is 1 ml once daily. If it is more than 2.5 kg, it is 15 mg, that is 1.5 ml once daily. And what if baby is below 2 kg? It is actually 2 mg per kg. Okay. And how much duration we should give? Infant with low risk of HIV transmission who is on exclusive breastfeeding or exclusive replacement therapy, 6 weeks we have to give. If infant with high risk of HIV transmission, if they are on exclusive breastfeeding, mind you, we should give it for 12 weeks. And if the infant is on exclusive replacement feeding, they have to give it for 6 weeks. So next is vaccination. What vaccination need to be given? Whether we had to give vaccine or not? These are the questions. So BCG at birth has to be given. Measles routinely given, but avoid only in severely immunocompromised HIV infants. And in measles, even if the baby is severely immunocompromised, once after baby attains immune reconstitution with ART, we can give measles. Or else the baby is detected at 6 months, previously not started on ART, better to give a measles because they are more prone to measles infection. So rotavirus, similarly, it can be given routinely, avoided in severely immunocompromised HIV infants. Pneumococcal vaccine, routinely given, but thing is here polysaccharide vaccine has to be given after 8 weeks of the last dose of conjugate vaccine in the children above 2 years of age. Only thing is you need to give booster, PPSV booster after 8 weeks, after the final dose of PCV. Inactive Japanese encephalitis, it is safe. A new live vaccine is available in Japanese encephalitis, but this live vaccine has to be avoided. Hepatitis B, since seroconversion is very less, 4-course double dose is required instead of single, like double the dose, whatever they are giving to normal kids in view of poor seroconversion. And you have to frequently check the serology levels of hepatitis B. If it is low, we have to again repeat with booster dose. Vitamin E supplementation, as per the national immunization schedule, there is no change with the vitamin A supplementation. This is about vaccination. So next is follow-up. So if a baby is born with HIV positive mother, we are starting prophylaxis, but what to do after that? So HIV exposed baby, there is an algorithm by NACO actually, neonatal testing algorithm for HIV-1 exposed infants and children less than 18 months. In this, HIV exposed baby born to HIV infected mother or baby referred by pediatrician or orphanage, if it is less than 6 months, more than 6 weeks, collect blood for DBS, that is dry blood spot, for HIV-1 PCR at ICTC. That means at 6 weeks, whatever, if more than 6 weeks, you have to send the baby to ICTC. Send the DBS sample for PCR, HIV PCR1 test. If it is detected, collect and send another DBS sample for HIV-1 PCR. If that is also positive, the babies should be started on ART. So if the first test is negative, then HIV exposed infant is closely monitored for the growth, development, and appearance of any signs of HIV infection. HIV-1 PCR can be repeated at any time if the infant becomes symptomatic. And first time it is detected positive, and second time if it is repeated, it is detected negative. For example, it is coming negative. So discordance. Lab will request for another DBS sample for the confirmatory HIV-1 PCR test at ICTC. And if whatever the result gets, you have to follow that. Like if HIV-1 is detected, then start an ART. If it is not detected, closely follow. So if the child is 6 months or more, then collect blood and test for HIV antibodies here using all 3 serological tests and prepare a DBS for HIV-1 PCR. If antibody is reactive for all 3, either 2 or 1 of the tests, then confirm with DBS, and if it is positive, follow the previous algorithm. If antibody is negative in all of the 3 and does not require HIV PCR testing by DBS, baby is probably not infected but is at risk. So you have to follow up the baby at 3 months, 18 months, like that. So this is about neonatal testing algorithm for HIV exposed infants less than 18 months. What about beyond 18 months? Baby presents at the ICTC at 18 months of age or later. So what is the HIV-1 infection status by previously done PCR test? HIV-1 not detected by PCR, HIV-1 HIV-1 detected by PCR. HIV-1 not detected by PCR. Test for HIV antibody. Test for HIV antibody for a definitive diagnostic using all three serological tests at ICTC. Antibody reactive on all three tests, baby is HIV-1 infected, initiate lifelong ART. If only two tests is reactive or one test is reactive, it is indeterminate. Repeat antibody testing after 2 weeks. If antibody non-reactive in all three tests, confirm HIV-1 not infected. So it is confirmed here. If HIV-1 is detected by previous PCR, test for HIV antibody for definitive diagnosis using all three serological testing. Again here antibody reactive for all three tests, then continue ART. Antibody reactive in two tests or one test or not reactive for either of the three tests. This is called serodiscordance. Continue ART and get all four tests done. What all four tests here? That is serodiscordance, continue ART and get all 5 tests done here. What they are given, that is contact linked EID laboratory. You have to go there, collect sample and send laboratory. That these tests has to be done, like 5 tests. That is all three rapid diagnostic antibody tests, HIV-1 ELISA, qualitative HIV TNA PCR, and quantitative HIV-1 PCR viral load and Western blot. If sample reactive on any of the 5 tests, continue ART. If not reactive, closely follow up. This is about follow up. So we learned about prophylaxis, follow up, feeding also. And now what if there is exposure to HIV by a healthcare person? That is, we'll directly go up on the post exposure prophylaxis. So they are divided into either exposure codes and source codes. Just we'll come to know what is exposure codes and source code. Then we'll go to what exactly we have to do. Whether the material is blood, body fluid, or other potentially infected material or instrument contaminated with one of these substances. Yes, then mucous membrane or skin integrity is compromised. Volume, small volume, a few drops or short duration, then it is EC1, that is exposure code 1. If it is large volume, major / long duration, that is 2, EC2. Always see this EC1. This we have to remember. Small volume, a few drops of short duration, mucous membrane, skin integrity compromised. If coming to next, intact skin, no PEP required. Percutaneous exposure, that is needle prick kind of thing. Severity, less severe, solid needle, superficial scratch, EC2. More severe, hollow bore needle, deep injury, EC3. So next comes to source codes. Source of the exposure, that is HIV status. If it is from HIV negative, PEP is not required. If it's HIV positive, low titer exposure, asymptomatic, high CD4 count, then HIV source code 1, that is SC1. High titer exposure, advanced disease, low CD4 count, that is HIV source code 2. If HIV status unknown, then HIV source code unknown. So keeping this in mind, we will go for source code. If exposure code and source code is 1, PEP is not recommended. This is the only thing we have to see. And if any of the other thing, like either exposure code 1, 2, 3 or source code 2, 1, whatever the combination, you have to give PEP. How much duration? That is 28. If source code is unknown, consider PEP if HIV prevalence is high in a given population and the region, risk depending upon the risk. If that region is, for example, in India, we have high prevalence, better to go with PEP. So what all we now know whom to be given, and now what all to be given, that is same TLD regimen. If the baby, if the adolescent or adult, it is RL more than 10 years or more than 30 kgs of weight. Whereas if it is children or more than 20 kgs of weight, you have to give zidovudine, lamivudine and if it is children less than 6 years of age or less than 20 kg, zidovudine, lamivudine along with lopinavir or ritonavir. So this is about post-exposure prophylaxis. And in summary, delivery room management, avoid routine suction and delayed cord clamping. Breastfeeding, NACO says exclusive breastfeeding for India, exclusive replacement feeding only if it is AFAS, AFASS, that is affordable, feasible, acceptable, and socially acceptable. And then next is prophylaxis, nevirapine if low risk, dual therapy if high risk. Vaccination, avoid live vaccine if severely immunocompromised, or else routinely you can give live vaccines also. Follow at 6 weeks at ICTC, and you follow the less than 18 months regime for flow chart. And then next is healthcare worker precautions. PEP to be initiated within 72 hours. I forgot to tell. Actually as soon as possible, but within 72 hours, and should be given for 28 days. This is about pediatric perspective. Hello.
Yeah, thank you, Purna, for summarizing the case there. I think many of you would agree with me that there are some minor changes to what NACO has done last year. So I think it's a wonderful presentation from both of you. So I would now like to invite Dr. Vandana ma'am to check any questions or any doubts. Vandana ma'am.
Sir, good evening. Both presented very nicely. The most good thing about this is mainly we discussed about the case scenarios. So everything was clinical, informative and all. So congratulations to both the speakers. As such, now the prevalence of HIV is very, very less compared to which was there 10 years back. So, and the government programs is very rampant and very approachable to all the people. So in that sense, we are very thankful that we have some proper streamlined method for all this HIV and all. So I feel now the pressure of that HIV patient has come down. But as sir said, we should be very much aware of prophylaxis and what drug should be used, and that we have to follow the guidelines. Otherwise, everything is very nicely presented, sir.
Any questions you want to ask them, ma'am?
As such, in private setups, we are not encouraging all this communicable diseases, HIV, HPSAG. We had reduced in private setups, but mainly institutional deliveries we prefer, because both the mother and the pediatric care will be taken properly. So I feel institutional people, everybody should be aware. And previously, this transmission rate of HIV was very high. I don't know, the virus has become weak or we have become strong or what. Now we are seeing very less, I can say less than 1 per 1,000 also in this right now present status.
Right. Any questions, anybody?
Sir, I had a question. Can the woman opt for exclusive replacement feeding? Can we document that she has opted for exclusive replacement feeding, and can we avoid breastfeeding in such a mother?
See, with current triple ARV and breastfeeding, the risk is negligible, but still some parents would actually want to give exclusive replacement feeding. So if mother wants to opt for replacement feeding, if they're able to fulfill the AFAS criteria, definitely they can go ahead with replacement feeding if the mother opts for it. She can opt. It's better to document that parents opted for it. It's better to have an antenatal counseling only rather than discussing with them after the delivery.
like most of the private hospitals, they manage HIV patients with the testing in their own center. So, so what advice should be given? So, like every patient should be referred to the ICTC and ART center. So, when should they refer, and how should we go about it?
Dr. Chandusha, you want to take up this question?
Any patient, whether it is private or government sector, patient will be attached. The patient will be informed to the ICTC counseling center. We will register there the patient, irrespective of whether she is a government patient or whether she's following up with the private sector. And accordingly, counseling will be done. So there is no much difference related to the management.
So what should be written on the discharge summary? Like, is it okay? Should we mention that the mother is retropositive, or should we maintain the confidentiality of the patient? So how should it be followed? Is there any thing you have to say about this?
So we need to end inequalities with respect to retropositive. I agree that, but we can mention on the discharge summary that they are retropositive, so that other healthcare workers or healthcare professionals who will handle that mother, they are well aware that mother is retropositive when they handle her or when they handle the newborn. So it's better to mention the retropositive status for the protection of other healthcare professionals.
Okay. So, think, for example, sometimes the mother is in the postnatal ward or anything. So we follow the criteria of, like in the NICU, like universal precautions we write it. So should anything be labeled in the postnatal ward near the mother bed or something that will cause a social stigma to the parents or the family? So how to go about it? Is there any other technique that we can follow to caution the healthcare workers or anything, or should we continue mentioning it as universal precautions like that? For example, even hepatitis B, HBsAg positive mother also, we can write universal precautions on the file, or sometimes near the bed we will write it. So is there anything new that can be done in this regard?
As you said, the challenges are quite high. It's a sensitive issue. No patient would like to stay with that patient who has retropositive or HBsAg positive in a sharing room in a private sector. So public sector fortunately has different wards for such cases. So probably in private sector, we can actually follow universal precautions. So better to mention on file. So mentioning on the ward actually can affect the privacy issue for the individual patient. So what we would do generally is that we would actually mention on the file, we would instruct the nurses to take care. We'll generally don't mention on the ward. Vandana ma'am, do you follow separately there in the sharing rooms?
Sir, here we completely segregate from the routine patients, including labor room, everything we used to segregate completely. And all the staff are being warned. Only one staff is being given in charge in each duty. Other than that, all staff were not allowed. So that was our method. And we never used to mention it was a retropositive or anything. We used to mention on the case sheet as biohazard. That's all. It can be HBsAg positive or HIV positive. So only the staff who is in charge of that patient would have been knowing that it is retropositive, and it will be handled separately. All the disposables, everything will be taken care of separately. There all the secretions, mattresses, everything will be disposed after that. That we used to do 10 years back. But when I was postgraduate, we had in institution, we had a separate HIV ward and all. So those things will be managed by the senior most staff, and only one PG used to be allowed to take care of that. That was the criteria when it was very rampant.
I think we agree with you. It's a nice way to mention us just as a biohazard and just have a segregate the patient there. We have space. Anil, hope that answers your question.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Definitely, ma'am has brought into notice regarding the waste segregation also, because these patients are very infectious rather than the routine infectious waste. These are potential biohazards. We have to take care of the waste management of these retropositive mothers and the babies also. HIV exposed infants also. We have to take care of the waste management, and we have to caution the waste collecting personnel also regarding the potential hazard of infection.
To add up on to the discussion, in neonatal discharge summary, better to write follow-up at ICTC at 6 weeks. Though they would be registered, but it will be our duty if HIV positive mother is there.
Right, Purna, right. Any other questions or doubts? If there are no questions or doubts, I think we thank both the speakers, Dr. Chandushri and Dr. Purnachandra, for their clear presentation. And we'd also like to thank the team of Sarji Hospital and Dr. Vandana ma'am for joining us. We thank all the participants. Thank you.
Thank you so much, sir.